Americans, what if your zip code impacts your health more than your doctor? Here's why US healthcare is changing forever. For years, hospitals earned more by performing more procedures. Today, the focus is shifting to value-based care, where better patient outcomes matter more than treatment volume. Rising costs, chronic diseases, food insecurity, unemployment, and unsafe neighborhoods are driving healthcare spending. Instead of only treating illness, hospitals are investing in prevention and community support. Healthier communities mean lower costs, better outcomes, and stronger hospitals. The future of American healthcare isn't just about medicine, it's about improving lives. Subscribe for more U.S. healthcare insights.
United States hospital systems are facing a severe and immediate profitability crisis. Structural economics, rather than a lack of patience, are driving the systemic decay. Hospitals are experiencing a paradox where rising healthcare demand and climbing inpatient volumes are actually accelerating the erosion of their operating margins. Operational expense growth has permanently outpaced revenue growth across nonprofit health systems. This chart tracks revenue and expense growth for nonprofit hospitals. Between 2015 and 2017, expenses permanently cross above the revenue line. This sustained gap indicates a systemic shift where the fundamental cost of care exceeds incoming capital. Traditional financial tactics, such as negotiating higher reimbursement rates with commercial insurance providers, are no longer mathematically sufficient to close the deficit. Standard administrative strategies are failing because the patient base today is older, poorer, and sicker than the demographic the system was originally designed to serve. Hospitals are caught in a payer mix trap. The fastest-growing patient demographics in the country are not those insured by private employers, but those covered by government programs. This graph illustrates prices paid for inpatient hospital services. With private health insurance plotted at a 100% baseline, government payers reimburse hospitals well below actual costs. Historically, Medicaid pays roughly 85 cents for every dollar of care administered. 10,000 newly eligible people age into Medicare every day, and Medicaid expansion continues. Treating a higher volume of patients from these demographics mathematically guarantees greater systemic financial losses for the hospital. The legislative and industry-wide response to this financial drain is the aggressive phase-out of the traditional fee-for-service model. Fee-for-service incentivized sheer volume. Hospitals were paid based on the quantity of interventions they performed, rewarding the treatment of acute sickness rather than the maintenance of long-term health. Payers and providers are pivoting to value-based care, tying financial compensation directly to patient outcomes. Hospitals now face direct financial penalties for high readmission rates. This completely transfers the financial risk from the insurance payer directly onto the hospital system's balance sheet. Waiting to treat highly complex, expensive conditions until the moment a patient is admitted is now a reliable path to bankruptcy. To survive value-based care mandates, hospitals must look beyond their clinical walls and intervene in the patient's life long before they require an emergency room. The heaviest drain on a hospital's government-insured resources comes from a specific profile: the high-risk patient suffering from overlapping chronic conditions. Just 17% of Medicare patients live with more than 6 chronic conditions, yet they account for half of all Medicare spending. To isolate the drivers of these costs, researchers at Washington University analyzed the 2014 HCUP National Inpatient Sample, parsing over 7 million unique hospital observations. They mapped 29 distinct high-cost clinical comorbidities against regional demographic data to identify the exact root causes of these admissions. Predicting and mapping these comorbidities give administrators the data they need to proactively mitigate the costs of their sickest demographics. These root causes are known as social determinants of health, the specific environmental and economic conditions occurring where a patient lives, works, and plays. The WashU model tested 3 precise socioeconomic variables: local violent crime rates, SNAP benefit distributions representing food insecurity, and regional unemployment. The medical industry recognizes the basic truism that poor social conditions correlate with poor health outcomes. However, vague correlation is mathematically useless for a hospital CFO attempting to justify a multi-million-dollar community investment to a board of directors. They face the endogeneity problem, the difficulty of separating cause from effect in social data. Does high local unemployment cause chronic illness, or does widespread illness cause high unemployment? Without proving causation direction, health systems cannot accurately predict financial returns on social investments. Calculating a bankable ROI requires a statistical mechanism capable of breaking this feedback loop to prove definitive one-way causation. Researchers solved this using an advanced econometric technique, the application of instrumental variables within a probit regression model. They introduced a macro instrument to break the loop: regional political affiliation. While a state's legislative leanings dictate the funding for SNAP benefits or unemployment programs, an individual's personal medical diagnosis has no power to change the partisan makeup of their state government. By isolating the portion of social conditions driven only by these top-down policies, the model can mathematically sever the reverse causation loop, proving the social environment is the initial trigger for disease. By passing the rigorous Wald test of exogeneity, the model provides hospitals with mathematical proof that social determinants directly and independently drive up inpatient costs. With causation established, the regression model generates raw, bankable financial output. The model tracked the specific financial impact of improving each social metric by exactly one standard deviation. The crime dividend shows that a one standard deviation drop in violent crime eliminates specific comorbidities, reducing total hospital costs by up to 0.21%. A standard deviation improvement in SNAP distributions drastically reduces food insecurity, decreasing inpatient costs by up to 0.5%. And a standard drop in the local unemployment rate creates a 1.7% reduction in systemic inpatient spending. For health systems with operating budgets measured in billions, a 1.7% reduction yields hundreds of millions in protected margin. The data includes a critical caveat. When researchers ran a microanalysis on highly standardized routine procedures, like basic joint replacements without complications, these cost savings disappeared entirely. This caveat confirms that the projected savings are explicitly generated by preventing the onset of complex chronic illnesses, rather than standard surgical efficiencies. The math proves that investing in a community's social fabric yields predictable, hard dollar reductions in direct medical expenses. Under modern value-based care models, health systems can no longer afford to ignore the socioeconomic realities of their surrounding zip codes. In this landscape, funding local economic development and food access represents an essential margin protection strategy, moving community investment from the charity ledger to the operational budget. To stabilize the hospital, administrators have to stabilize the city around it.